Hello everyone, this is Dr. Meenakshi Gupta. Today we are going to discuss anti-anginal drugs. We know the anti-anginal drug, they are the drug which we use for the treatment of the angina as well as we can use it for the prevention. So this is the anti-anginal drug, classification of the anti-anginal drug. This I have taken from the KD Tripathi. So you can see the various group. The first one is we have a nitrate, then we have a beta blocker, then we have a calcium channel blocker, potassium channel opener, and various other anti-angina drug. So in this video, I will be discussing about the beta blocker and calcium channel blocker. So nitrate I have already discussed in my previous video. Link will be given in the description box. If you haven't watched it, you can go and watch it. So now coming to the beta blocker. Beta blocker, you know, in the heart we have a beta receptor. ठीक है, हार्ट में कौन से हैं? We have a beta receptor, and which subtype? It is a beta 1 receptor. They are there. So a sympathetic stimulation of this beta 1 receptor, it is going to cause what? There will be increased force of contraction, increased heart rate, and increased contractility. So all the things will be increased. So there will be increased heart rate, increase force of contraction, increase contractility, same thing it is, and all the positive inotropic, chronotropic and dromotropic, even conduction will be also increased. Okay, these two are same. So there is a chronotropic effect, this is heart rate, this is inotropic effect, and this is a dromotropic effect. So if we are going to use the beta blocker, now what the beta blocker they are going to do? They are going to reverse all these changes. They are going to decrease the heart rate, negative chronotropic effect will be there. Okay, negative inotropic effect will be there, and negative dromotropic effect will be there with the beta blocker. So with all these, what they are going to do, beta blocker, they are going to decrease the myocardial oxygen demand and thus decrease the cardiac work. This is what we want in the, especially in the classical angina or stable angina or exertional angina. We have to use the drug which can decrease the cardiac work. So this effect, it is not very much obvious, or you can say it is very marginal at rest, but marked whenever there is a sympathetic stimulation, whenever the person is doing exercise or is tense or anxious, that time the effect of beta blocker will be marked. Now which beta blocker is to be used? It is not beta 1. So we can use cardioselective or non-selective. So cardioselective, definitely they are to be preferred over the non-selective, because in the heart there is a beta 1 receptor. Though if we are using the beta 2 receptor along with that, or non-selective beta blocker, sorry, then what they are going to do, they are going to decrease the maybe coronary spasm. They are going to cause a coronary spasm. But in the subendocardial region, where ischemia is there, because of ischemia already vasodilatation is there. So it is not going to affect much. But this effect is marked. They are going to decrease the myocardial oxygen demand and they are going to decrease the cardiac work. Now beta blocker, they are to be used in which type of angina? So you know we have three type of angina. One is we have a classical angina. So of course we can use this drug in a classical angina because it is going to decrease the cardiac work. And cardioselective metoprolol, atenolol. So atenolol, metoprolol are to be preferred over non-selective propranolol. Now coming to the variant angina. So in the variant angina, this group of drug, it is a big no, whether cardioselective or not, because variant angina, that is because of the coronary vasospasm. That is because of the coronary vasospasm. If we are going to use this group of drug, cardioselective, it will be showing no effect because in the vessels there are beta 2 receptor, they are there. So cardioselective will be having no effect. Okay. So this group of drug, rather we will say it is a contraindicated. If we are going to use a non-selective, whether it is beta 1 or beta 2, what will happen? Because of the blockade of that, there will be alpha mediated vasoconstriction. So usually here important question is, why beta blocker they are contraindicated? Beta blocker are contraindicated in variant angina. Whereas in unstable, last one is in unstable angina and even in non-segment T elevation myocardial infarction, we can use the beta blocker because here also they are going to decrease the myocardial oxygen demand and they are going to decrease the cardiac work. Okay. So what are the important adverse effect with the beta blocker? So we know beta blocker we cannot, it is going to cause we cannot use it in a CHF, especially in decompensated CHF. Then if the person is having bronchial asthma, let's see the next slide. So you can see the contraindication, we have a bronchial asthma, we have a peripheral vascular disease because it is going to cause also AV blockade or severe bradycardia. So this should not be given with the other drug which can cause the bradycardia like calcium channel blocker. They are also cardiac depressant. So if you are going to give beta blocker with the calcium channel blocker, then what will happen? There will be AV blockade. So these two drugs, they are not to be used together. Then CHF or left ventricular failure, if it is a decompensated, it can worsen, this already I have told, it can worsen the variant or vasospastic angina due to unopposed alpha mediated vasoconstriction. So these two, they are important question. Why beta blocker they are not to be given with the calcium channel blocker? Why beta blocker not given with the verapamil and diltiazem? If we want to use the beta blocker with the calcium channel blocker, we can use the dihydropyridines. So this is all about the beta blocker. Now coming to the next one, calcium channel blocker. So there are the three classes of the calcium channel blocker. We have dihydropyridines, we have benzothiazepine and phenylalkylamine. So dihydropyridines, they are lipophilic. ये आपके lipophilic है and they are the most potent among all the three. So you know potency, it is the amount of the drug which is required to produce a response. Then these two, they are hydrophilic and as compared to this, they are less potent. Now this calcium channel blocker, they are going to act by blocking the calcium channel. Now how many type of calcium channel they are there in the body? We have three type of, rather there are four type of calcium channel. One is voltage sensitive, second one is a receptor operated. You can see in this figure, this I have taken from the net. So voltage sensitive, they get operated whenever the voltage it falls below 40 millivolt or less than this. Then these channel they get open. Receptor regulated, when any agonist it binds adrenaline, if suppose that binds with this, then this channel it gets open. Number 3 is, it is a leak channel. So leak channel, there would be the leakage or stretch channel. Because of the stretch, the channel they gets open and the calcium it leaks from that channel and it moves inside and it comes out with the inside movement that is based on the calcium ATPase. Then a fourth one is sodium calcium exchange. So this is mainly when we read about the digoxin mechanism of action. So otherwise for the calcium channel blocker drugs, they are not going to act through this, they are not going to act through this, they are not going to act through this. They are going to act through this voltage sensitive calcium channel. And you can see in this figure only the voltage sensitive calcium channel, they are of three type. We have L type, we have T type, and we have N type. You can see in the next figure, this again I have taken it from the KD Tripathi. So here the most important is what are its location. So you should focus on this, and important blocker. So activation rate, if you want, these are the L type, they are the slow, this is the inactivation rate, and activation threshold, low, high, and this, if you know, it's okay, especially this one, it is a low type activation threshold. So this L type, they are mainly present in the cardiovascular system. This is the one, long lasting current. T type, that is mainly T, remember, with the T thalamic. And this you can leave also in the neurons. Okay, this is present only in the neurons. You can leave only, there is a one drug which act by blocking the N type of the neuronal channel, L type, N type of the calcium channel, sorry. So this T type which is present in the thalamic, so there is a one drug which already I have explained in my video on the anti-epileptic drug like ethosuximide. It act by blocking this T type of calcium channel. It blocks only T type of the calcium channel. So we use it for the treatment of absence seizure. And most of all the three classes of the drug, dihydropyridines, phenylethylamine, and benzodiazepine, all they act by blocking this L type of calcium channel. So you can see all the drug, dihydropyridines में आपका nifedipine है, ठीक है? Then phenylethylamine, verapamil, and benzodiazepine, diltiazem. All the three they are there. And with the N type, there is one dihydropyridines which is going to block L type. Along with the L type, it also block the N type of the channel. That is clinidipine. Clinidipine. Okay. So these dihydropyridines, they are mainly DIPIN. They end with this. So now this L type of calcium channel, what is this, where all these three group of the drug, they act by blocking voltage sensitive L type of calcium channel. Now this L type of calcium channel, they have mainly alpha 1 subunit which is going to enclose this ion pore. Along with that, the other subunits we have, you can see alpha 2, you can see delta, beta, and gamma. And all the three drugs, they mainly bind with this alpha 1 subunit, and their site, it is different. At different site on alpha 1 they are going to bind, and with this all these alpha 1, alpha 2, gamma, beta, and this one delta, they are going to form different isoforms at different sites. Like in the smooth muscles, with the three type of muscles, skeletal muscle, smooth muscle, and cardiac muscle. So they have different type of isoforms. They are there at different site. So drugs, they are going to bind with the different, even in the vascular, in the smooth muscle may they say vascular and other smooth muscles, the isoforms, they are different, and the drug, they have a different affinity for the different isoforms. So site specific action हो गया for all the three type of the calcium channel. Few they have got more affinity for the smooth muscle, few they have more affinity for the cardiac muscle. So depending upon their affinity for the different isoform, they are going to perform different actions. So their action will be also different and their therapeutic uses, they are also different. Okay, you got it? So there are different isoform based on this. In the skeletal muscle, in the cardiac muscle, in the smooth muscle, different isoforms, they are there. And these three classes of calcium channel blocker, they have different affinity. They have site specific affinity for that, and accordingly they are going to perform the action. So this calcium channel blocker, they are mainly going to act on smooth muscle and cardiac muscle. These are the two important site of this. So mainly they block L type of the calcium channel, where in the smooth muscle and in the cardiac muscle. In the smooth muscle, they are going to cause the relaxation, whereas in the cardiac muscle, they have all the negative inotropic, heart rate chronotropic and dromotropic. So all the negative. So this action, it resembles with the beta blocker. So beta blocker, they are also having the same action. Calcium channel blocker, they are also having same action. So that's why beta blocker and calcium channel blocker should not be given together. Otherwise, what will happen? There will be AV blockage. So this is the reason. Now, which calcium channel blocker we can give? So we will discuss shortly with that also. Now, in the smooth muscle, what is the mechanism of action over here and mechanism of action here in the cardiac muscle? So how it is going to cause the relaxation of the smooth muscle? So this drug in the smooth muscle, again I have taken this diagram from the tripartite. So same diagram I have used for the to make you understand about the mechanism of action of the nitrate. So here how this smooth muscle, they contract. The calcium, it enters through this L type of, this is voltage gated L type of calcium channel. Once it enter, it is going to cause the release of more amount of the calcium which is stored over here. Now this calcium plus this calcium, what they are going to do, these two, this one and this one, they are going to cause the phosphorylation of this myosin light chain kinase. And you know, if this get phosphorylated, then what will happen? They are going to cause this contraction. Okay, they are going to cause the binding of this myosin light chain phosphorylated. It is going to cause the binding of this actin filament and there will be contraction. Now, if we are going to block this with the calcium channel blocker, okay, they are going to block this, then what will happen? All these things will not happen. Then what it is going to cause? There will be relaxation of the, so this is about the smooth muscle, there will be relaxation of the smooth muscle. But this drug like nitrate, they were venodilator. This is the difference. They are mainly venodilator. And this calcium channel, they are mainly arteries, arteriolar dilators. So this is the difference. Why they are more venodilator, I have explained in that video. So this mainly act on the artery. By acting on the arterioles, they are going to cause a dilatation of the arterioles. Then what they are going to do? They are going to decrease the afterload. Okay? By they are going to decrease the afterload. So it is the resistance against which heart has to pump. So this is going to decrease the cardiac work. So this is how the calcium channel blocker, they are going to help in the angina, especially in the classical angina. Along with that, they are also going to cause the relaxation of the epicardial artery. ठीक है, जो आपके ऐसे मसल में एपिकार्डियम ऊपर दिस आर्टरी, they are also going to cause the relaxation of this, plus intramyocardial artery, it is going to cause a relaxation of that. So it is going to improve the coronary flow also. Okay, now this is its mechanism of action in the smooth muscle. Now its mechanism of action in the cardiac muscle or cardiac cell, how it is going to act over there. So in the cardiac or in the heart, and especially in the atrial and ventricular muscle fiber, where this calcium ion they play. So influx of the calcium happens. So these are the phases of action potential of the atrial and the ventricular fiber. Okay, so this is phase 0. This is phase 0, this is phase 1, this is phase 2, this is 3, and this is 4. So this calcium, it entered during this phase. This is a plateau phase. This is in the atrial or ventricular action. Potential. Now this calcium, it enters over here, and then it is going to cause the release of the calcium from the sarcoplasmic reticulum, and that calcium binds with the troponin, and what it is going to do, it is going to cause the activation of both myosin and actin filament, and contraction will happen. Now if we are going to give this calcium channel blocker, then that will not happen. So there will be no contraction. So this way it is going to act over here. Whereas in nodal action potential, if we see nodal action potential, this AV or SA node, this phase 0, that is dependent on calcium channel. This phase 0, this is dependent on the calcium channel. So calcium channel, they are going to block this phase SA node and AV node. So they are going to decrease the pacemaker activity and conduction. So they are going to decrease all heart rate, conduction, and contraction. So all the three will be affected. Now this calcium channel, here it is a sodium channel. Now what type of channel it is? Here you can see this type, this is a action potential, and this side it is a, or on x-axis it is a time. ठीक है, यहाँ पे हम potential लिखते हैं, यहाँ पे हम not action potential, here we see the voltage rather. The appropriate is, it is a, here it is this side, y-axis voltage, and this side time. So if you can see here in the atrial or ventricular action potential, the phase 0, that is dependent on the sodium ion. So you can see in no time there is an influx of the sodium, whereas here it is going to take the time. So calcium channel, they are a slow channel. Now we have the three phases, just like a sodium channel. That also sodium channel I have explained in the local anesthetic, so you can go and watch that video also. Here the same way the calcium channel, it also exists in three form: resting phase, so it is not a channel, it is a resting phase, activated phase, and inactivated phase. So you can write the channel also, that is also correct. So resting, activated, and inactivated. So this group of drug, they are mainly going to block here. They either block this or this. Either they block activated, open channel, activated, or open channel. They are going to block open calcium channel or inactivated. Then from this to this, it will happen only once the channel from inactivated state, it gets recovered. Okay? From inactivated, if it is going to recover, then only we can, it has to come to the resting phase, and then it gets activated, and then it goes to the inactivated. Okay? So it is never, this movement is not like this. What I want to make you clear. So the channel, it is in a resting phase, activated phase, and inactivated phase. From the inactivated, it will never come to this. It has to recover. And this calcium channel, especially this verapamil and diltiazem, and this is the time dependent. It is not dependent on the voltage. Just see here. So this is not dependent on the voltage. अगर यहाँ पे है, it is going to take the time. So this is a time dependent, and verapamil and diltiazem, they are going to delay this recovery. So they are going to decrease the heart rate and they are going to slow the conduction. Now what about this, the cardiac and the smooth muscle? Now we have a three group of the drug. We have no dihydropyridines. They have more affinity, or at low dose they are going to block this smooth muscle cells calcium channel more evidently at low dose, and at that dose they are not going to block this cardiac channel. Okay, so dihydropyridines at low dose or at a particular dose, they are going to the dose which we are going to use for the smooth muscle relaxation, that dose is not sufficient to depress this one. Similarly, the verapamil and diltiazem, they have more affinity for the cardiac, or in other words, you can remember the dihydropyridines, they have more affinity for the calcium channel which are present in the smooth muscle, whereas the other two group, they have more affinity for the calcium channel which are present in the heart. So how you can remember this one? So we have a two group of drug. One is dihydropyridines. Okay, use different color. One is dihydropyridines. जिसमें आपके nifedipine and all that comes. Another one is a non-dihydropyridines. So if we make a this non heart, so this has got more action on the cardiac calcium channel. You can see the differentiating point about all the three, verapamil, nifedipine and diltiazem. In the first slide only I have told potency, the maximum potency, that is with the nifedipine as compared to the other one. Okay? So this is a potent and this is a next and this is a third one. Then this channel blocking potency, it depends upon the frequency. Okay, channel blocked frequently, how frequently this channel is opening, activated or inactivated. So that is, if it is a more active than verapamil, it is going to block that if the channel is keep on blocking, whereas nifedipine, it does not have any this one, and this is as compared to the verapamil, it is less. Then channel recovery rate, they are going to delay, whereas nifedipine, which is mainly has got affinity for the this one smooth muscle, so they are not having any effect on the channel recovery. Then next one is, I want to vascular smooth muscles relaxation. So nifedipine, it has got more affinity on the vascular smooth muscle. This is a number 2 and this is number 3. So by acting on the vascular smooth muscle, they are going to decrease the blood pressure. Okay, all of them, they are going to decrease the blood pressure. Now coming to the heart rate. So heart rate, you can see here it is increased, here it is decreased. Okay. Now increase is whenever there is a sudden fall in blood pressure, there will be reflex tachycardia. So this is a indirect. Here also the indirect is there. Here also the indirect rise in blood pressure, that is there. But verapamil and diltiazem, they have more affinity for the cardiac, so they are the cardiodepressant. They are going to bind with the SC node. They are going to decrease the heart rate. So their direct effect is depressant. So they are cardiodepressant. Then what will happen? This cardiodepressant action, it is more in comparison to this reflex tachycardia. So ultimately net effect is there is a decrease in heart rate. Same way is with the diltiazem. Whereas with nifedipine, it does not have any cardiodepressant action. So it is going to increase the heart rate. Okay. Same, the conduction velocity, that is decreased with these two. Contractility, that is decreased, and where it is increased. Now where we can use this one, all the three we can use it for the angina, whether it is a verapamil, nifedipine or diltiazem. You can see here. Okay. Whereas nifedipine, it has got more action on the smooth muscle. It is going to cause a relaxation. So we can use it for the hypertension, for the peripheral vascular disease, whereas verapamil, its main action is on the heart. So we can use it for the SA node, for a AV node. So we can use it for the atrial flutter, for the atrial fibrillation, for the PSVT arrhythmia. So we can use it here. And this is the third one. Optional uses hypertension. Here optional uses arrhythmia. Now coming to the next one, pharmacokinetic. Important pharmacokinetic feature. By this slide you can see the elimination half-life. That is maximum, whether this is a longest acting. Second one is, if we look at the bioavailability of amlodipine, it is in comparison to rest, it is more, because all they undergo high first pass metabolism, but this does not go in this. This one is only important, and half life, that is this is the longest one. There are other also, they are there. So no differentiating points with all that. Three I have told: verapamil, diltiazem and nifedipine. Now dihydropyridines, there is a long list. So here you can see with the highlighted, which the highlighted one, the yellow color, they are the short acting. Clinidipine don't contain, there are the three. Nifedipine, we have a nimodipine and nicardipine. They are the short acting. Okay, whereas with the pink tick, जो आपके pink tick है, amlodipine, vanadipine and falodipine. So they are the long acting, whereas the other with the round circle with the green color, lecidipine, nitrandipine, lercandipine and clinidipine, they are the intermediate acting. Okay, so now what are the special point with this, you will be reading in a therapeutic use also, like nitrandipine, this is used in hypertensive emergency. It's also a short acting, and we prefer it because it is a selective. It is going to cause a vasodilatation of the cerebral blood vessel and coronary vessels. So that's why it is used IV infusion, that is given for the hypertensive emergency. Clinidipine, already I have told, they also block the N type of the calcium channel along with the L type. So reflex sympathetic stimulation, that is not seen. So we prefer this one for the angina and hypertension. Sorry, here it is a nicardipine, the short acting one, that is used for the hypertensive emergency. Nitrandipine, it is not for the hypertensive emergency. I just want to make a correction, this is not for the hypertensive emergency. So nicardipine, this is a short acting, this we use for the hypertensive emergency, and this is preferred over the sodium nitroprusside, because sodium nitroprusside, they cause the release of cyanide and thiocyanide, which have got the toxicity or toxic effects. So this one is a safe. So nicardipine, this is used for the hypertensive emergency. They are the short acting, we give the IV infusion, and this is a safer version. And then nimodipine, it is used for the neurological deficit following subarachnoid hemorrhage. So it is following after the it is not during the subarachnoid hemorrhage. After the subarachnoid hemorrhage, there is a cerebral vasospasm that can lead to the deficit. So to prevent that, we are giving a vasodilator. Why nimodipine? Because they are selective for, they cause a selective dilatation of the cerebral blood vessel. So this is an important point about the nimodipine. Then coming to nitrandipine, what it causes, it is going to cause the release of NO, okay, from the endothelium, and it is also a phosphodiesterase inhibitor. So it increases the level of cyclic AMP. So vasodilatation effect, that is more with nitrandipine. Okay, this is important. Then lecidipine, what it does, it is going to limit the development of new metabolic syndrome and then new diabetes. So this is a differentiating points with all the rest of the calcium channel blocker. Now where we can use it? We can use it for all the type of angina. So number one is angina. So in the classical angina, in the variant angina, and in the unstable angina. So in the classical angina, they are how they are going to help in the classical angina, because they are going to cause a relaxation of the arterioles. This is going to decrease the peripheral vascular resistance and decrease the afterload and decrease the cardiac work, decrease the oxygen demand. Okay? So it also causes the increased flow of the epicardial artery. So increase coronary flow. Then if we are using verapamil, it has got the, so all the three calcium channel blocker, I already told that we can use it for the angina. Verapamil, it has got the cardio depressant action. So that is also going to decrease the cardiac work. So this is about the classical angina. In the variant angina, they are going to cause a relaxation of the epicardial artery and intramyocardial artery. So this is how it is useful in the variant angina. In the unstable angina, this is not the number one drug for the unstable angina. So in the unstable angina, we can use it with the other drug. Suppose we have given the nitrate. If the nitrate person is not getting a relief with the nitrate, which is mainly a vasodilator, we can add this. Otherwise, alone this drug, it is, and along with many other, so we can use antiplatelet drug and unstable angina. Okay. Then number two use is for the cardiac arrhythmia. So on angina, mein all the three drug we can use. And whereas cardiac arrhythmia, here we can use mainly which has got more affinity for the cardiac calcium channel, that is a verapamil and diltiazem, because they are atrial fibrillation and flutter and PSPT. So what is an atrial fibrillation or atrial flutter? So atrial fibrillation, it is the atria, it beats at the rate of, you can say, 200 to, so this is, I'm talking about atrial flutter, 200 to 350 beats per minute. Okay, so if we are going to give the verapamil, it is going to slow the AV conduction. So what will happen out of this? Only few will pass through the AV node, and it is we have to control, in all these conditions we have to control the ventricular rate. So verapamil, by slowing this AV conduction, it is going to help in regulation of the ventricular rate. So we can regulate the ventricular rate by giving the calcium channel blocker. Okay. Then for the hypertension, so for the hypertension, we are using dihydropyridines. They are preferred. So dihydropyridines, especially like if we are giving dihydropyridines, they are going to act mainly on the smooth muscle. They have affinity for the smooth muscle. They are going to cause a relaxation. So we can use dihydropyridine for the hypertension. So amlodipine, very commonly used as an antihypertensive. So this drug we can use as an antihypertensive where beta blockers, they are contraindicated, like in a bronchial asthma, in the CHF, okay, in the peripheral vascular disease, जहाँ पे आपने during the pregnancy we can give the this one amlodipine. Then hypertrophic cardiomyopathy, because of the inotropic, negative inotropic effect, this is going to help. So these are the cardiac uses of calcium channel blocker. Now coming to the non-cardiac. So cardiac आपके क्या angina, then we have a hypertension, तीन मैंने angina, hypertension, cardiac arrhythmia, hypertrophic cardiomyopathy. Then coming to the non-cardiac, our extra cardiac. Non-cardiac uses, we are using it for the migraine prophylaxis, because this drug, they are going to cause the dilatation. So what they say, the migraine, the initial attack, that is because of the vasoconstriction. Okay. So when I'll take a video on migraine, so there I will explain it. Nimodipine, that is used for the migraine prophylaxis. Then another one is a verapamil, nifedipine and flunarizine. So these we can use for the migraine. Nimodipine, where else we can use? It is neurological deficit due to cerebral vasospasm after the rupture of subarachnoid hemorrhage. So it is post जब when subarachnoid hemorrhage it is there following the rupture, it is when that is there, that time you are not supposed to give. It is after that there will be vasospasm, and then that leads to neurological deficits. To prevent that we can give. Then for the peripheral vascular disease, Raynaud disease, वहाँ पे हम दे सकते हैं in stopping the preterm uterine contraction, then vertebrobacillary insufficiency, for the vertigo, and for the epilepsy. So these are the non-cardiac uses of the calcium channel blocker. Now coming to its important adverse effect. Important adverse effect is because of the vasodilatation, especially the arteriolar dilatation. This can cause a headache, flushing, tachycardia, orthostatic hypotension, dizziness, digital dysesthesia. Patient also experience coughing, wheezing, pulmonary edema. So here important is because of the relaxation of the intestinal muscle, it can cause a constipation. This is very important, and especially verapamil group of drug, they are very important to cause the constipation. Then gum hyperplasia. So another drug is phenytoin, anti-epileptic drug, which can cause the gum hyperplasia. Then ankle edema. Ankle edema, it is not because of the fluid retention. It is because of the, there is a pre-capillary dilatation and post-capillary constriction. That is going to increase the hydrostatic pressure, which is going to lead the ankle edema. And it is seen mainly with the dihydropyridine nifedipine. That is going to cause the ankle edema. Then aggravation of MI. This is also seen with the nifedipine. Now what happens with the nifedipine? It is a short acting drug. So it is going to cause vasodilatation. So with that vasodilatation, what nifedipine, how it is going to cause? It is going to cause nifedipine. There will be vasodilatation. This is going to decrease the blood pressure, and ultimately what will happen? There will be reflex tachycardia. Heart has to work more, and that is going to cause the aggravation of the MI. Okay? So another important is this, already I have discussed, verapamil should not be given with the beta blocker. So beta blocker, all the negative, and even this is also cardiodepressant. So if you have to give any calcium channel, if you have to give it with the dihydropyridines. उसके साथ आपने देनी है. We have to give it with the dihydropyridines, not with the other verapamil. It should not, otherwise AV blockade will be there. So that's all about the beta blocker and the calcium channel blocker. So here the important question, this already I have told, why verapamil should not be given with the beta blocker. Here the again beta blocker in the angina, role of beta blocker, so we use it for the prophylactically. Then calcium channel blocker, it is you may get main question also, classification of the calcium channel blocker, right? Its therapeutic uses and adverse effect. Then calcium channel, role of calcium channel in the angina. So you have to write the mechanism of action. So whenever you are writing the mechanism of action of the classical angina, focus it is going to decrease the cardiac work. And whenever you are writing the mechanism of action for the variant angina, mainly focus on it is going to reverse the vasospasm. That's all. So if you like my video, please like it, share it, and subscribe my channel.